Hi, I'm Dr. Denise Milne, Executive Director of the Alberta Continuing Care Association. I would first like to extend our thanks to Cepheid for sponsoring this episode. Cepheid is a cutting-edge global diagnostics company at the forefront of molecular diagnostic innovation. Renowned for their state-of-the-art technology, Cepheid delivers rapid and highly accurate testing solutions for a broad spectrum of conditions including flu, RSV, and COVID-19. Their groundbreaking system, the GeneXpert Xpress, acclaimed for its ease of use and reliability, is transforming patient care and public health at the point of care on a global scale. Today is the third and final episode of our respiratory illness series for the 2024 season. I'm thrilled to welcome Dr. Scott Sugden, who is joining us today to discuss enhancing respiratory health in long-term care. Dr. Sugden is an expert in human immunology, focused particularly on infectious diseases and immuno-oncology. He completed his postdoctoral fellowship at McGill University in the Department of Experimental Medicine after receiving his PhD in microbiology and immunology at the University of Ottawa, where he studied immune evasion mechanisms of HIV. He has over 20 years of experience in biomedical environments spanning from preclinical basic research to phase 3 clinical trials. He has vast experience in the validation of both systems and assay. Thank you for joining us today, Dr. Sugden. I do want to ask you what's behind the meeting of Cepheid. It's such an interesting name for a company, and so I just thought it would be important for the audience to understand, like, how did you come up with that?
Yeah, well, I didn't come up with it, but originally a Cepheid is a astronomical event. When looking into deep space, astronomers noticed these regular pulsing signals of light, and they were so regular that you could actually use them to estimate distances. And at some point, I think they even thought they might be signs of intelligent life out there. I think now we understand that they're a type of star. So voila, that's where the name comes from. Our technology is a thermal cycler, so it's a technology that goes through a regular cycle of energy. So the name's apropos.
Yeah, that's fantastic. Thank you for sharing that. So today we have a number of questions for you. And so I'm just going to begin with getting into the questions because I think your technology is absolutely fascinating. For our audience, we want to understand if you could actually explain what molecular diagnostics are and how it differs from sort of traditional diagnostic testing.
Yeah, sure. So when we speak of molecular diagnostics, usually we're referring to a set of technologies that identify certain conditions by detecting the presence or, in theory, the absence of macromolecules. Usually we're speaking about RNA and DNA. Things that set this technology apart is that it's a relatively rapid technology, so you can get results on the order of minutes to hours, as opposed to hours to days that some contemporaneous technologies take. And also, a lot of these molecular technologies involve an amplification of the RNA and DNA present in the original sample. So they tend to be more sensitive. You can detect conditions at very low levels.
Okay. So has molecular testing technology advanced in the recent years? And can you tell us more about the point of care application?
Yes, sure. It is a technology that is still actively being innovated. You know, it hasn't hit the end of its potential. And I'd say in recent years, it's been developing along two general branches simultaneously. On the one hand, we're seeing tests that are more complex. They're able to detect more and more DNA, RNA targets out of one original sample. And for the moment, those tests still reside mainly within traditional laboratory spaces, requiring laboratory technicians to run them. And then in parallel, we're seeing the development of tests that are more and more simple and simplified. These tests will be, quicker, require a simpler workflow, present the results on an interface that is easier to understand. They might be smaller and take up less of a footprint on a bench. And it's this second branch of technology that we're going to see moving more and more into point of care locations away from traditional laboratory settings.
Okay, fantastic. So why would the point of care molecular testing be of a benefit to long-term care settings? And Scott, I want to throw in, because of the changes happening in Alberta with the continuing care sector and it moving from, Alberta Health over to Seniors, Community and Social Services, it's sort of, Seniors, Community and Social Services would say they do continuing care, and they do, right? So they have people with very complex needs, people in their Persons with Developmental Disabilities program, Family Support for Children with Disabilities program. So it's sort of stretching out continuing care, beyond just seniors, but seniors are really, really important, and we never want to lose sight of them in continuing care. But can you share with us why this point of care molecular testing would be a benefit to the continuing care sector in Alberta?
Yeah, I appreciate that. So I think across Canada and within Alberta as well, we're seeing more and more stress on our emergency departments, and we're looking for ways to move care closer to the patient to kind of alleviate the stress on our acute hospitals, specifically the emergency departments. So, I think as we age, or if we require extra care, we have more morbidities, more interactions with healthcare than otherwise the average person. So by getting testing into these long-term care, continuing care environments, one, we alleviate the hospital system, but two, and probably more importantly, we can get the results that people need sooner, so we can action those results and give people the care they need quicker. If we think of communicable diseases in particular, there's an added factor in that a lot of these long-term care environments tend to be congregated living to some degree, more than other places in society. And of course, communicable diseases, particularly airborne diseases or diseases that are spread by aerosols, are really going to take advantage of that congregation. So getting testing into those systems can do a lot of good.
So, for example, Scott, if I was in long-term care and, let's say they thought I had COVID or whatever, a respiratory illness of some sort, normally I would wait like days to get results. So that means I might potentially be sitting in my room, isolated, away from people. So I'm not able to socialize. I'm not able to eat with people. Everybody's coming into my room with masks on, that kind of thing. Your testing would allow for a quicker turnaround, so I would know what I'm dealing with. The nurses would know what they're dealing with, and we could sort of wrap around the care the best way possible in a much more timely and responsive way.
Yeah, so if we're speaking of respiratory infections like COVID in particular viral respiratory infections, point-of-care molecular technology has a bunch of advantages. First off, like you're mentioning, the time to result means that an individual that has SARS-CoV-2 or influenza or RSV can be identified quicker, and infection prevention measures can be put in place quicker. And hopefully prevent onward transmission. That individual, particularly important for the viral infections, can get access to viral medications sooner. And those, relative to antibiotics, need to be started as early in infection as possible to have the greatest effect. But also, as you mentioned, for the individuals that end up negative, they can get out of isolation much quicker. There's obviously costs associated with isolation in terms of protective gear and perhaps opportunity costs for beds that are empty that could be filled. But there's harms to patient. People don't like being isolated. It brings anxiety, it brings depression. So bringing testing to those environments for viral respiratory infections has huge benefit beyond the other benefits that other communicable diseases might have.
Fantastic. So, Scott, can you think of any other benefits? Like, one of the things that pops up for me is also for staffing, right? The quick turnaround of this testing allows me as a nurse or healthcare aide or physician to provide the best practice as soon as possible in a responsive manner to that patient or that resident in long-term care or that individual in, let's say, a group home and community, so that staff too aren't being impacted with making sure that their health is okay.
Yeah, so it's worth pointing out another specific advantage of molecular technologies is that high sensitivity I mentioned earlier. What that translates to is high sensitivity, meaning that you can detect a very little bit amount of SARS-CoV-2 or influenza in a person's body. What that translates to is being able to detect the infection earlier in the infection's course.
Nice.
For example, on day 1 of symptoms, as opposed to day 3 or 4. That might be the case for other technologies that are also amenable to the long-term care, continual care space, like antigen testing. Because you can detect early, you can implement your infection prevention processes early, you can protect your staff better, and relative to the other technologies in this space, indeed.
So what are some challenges faced when implementing molecular testing in long-term care settings? And I'm going to throw in complex needs. And how can we overcome those challenges?
Yep. Of course, there's challenges when all things, particularly when we're moving away from the status quo or implementing new systems. Number one, cost. Molecular technologies, almost all of them require a device. So there's, a capital purchase upfront. And then on a per test basis, they can be more expensive relative to their contemporaries, like antigen testing or sending away to a hospital. There's challenges around quality management. And what I mean by that is, how do we ensure that the test results we get on day 500 of using a technology are just as accurate, just as sensitive, just as precise as on day 0 when we first unbox that new machine. And that involves both staff training to make sure that the staff continues to, on an ongoing and continual basis, continue to perform the test correctly, but then also quality control and quality assurance measures to ensure that the device and the test lots themselves continue to perform the way they're supposed to. Third thing, which is really falls under the umbrella of the second thing, quality management, is data stewardship and data management. So from the initiation of sample collection all the way to the final result at the end, how are we ensuring that we're naming the sample correctly to ensure that it stays associated with the right person? Once the test results are available, how are we ensuring that those test results are stored in a manner that is, 1, robust, so if a computer crashes, you don't lose all the data, and 2, accurate. So again, the data isn't becoming more and more cumbersome as it moves from one Excel file to another, to the health record, et cetera.
So, Scott, I'm going to be a little bit bold. So, lots of integrity within managing the data, which one would hope would be in the traditional method of, testing. So that's possibly easily transferred with a little bit more robust character, I would say, based on your work. That's doable.
Yeah, I mean, presumably there's some degree of testing or data management already occurring in these environments. So there is a lot of transferal of what is already or has already been happening. I think added advantage is because molecular technologies need a device, a computerized device, unlike rapid antigen technologies, or at least all rapid antigen technologies. The test results can be immediately interfaced with databases and linked into wherever that data needs to end up in the end, and doesn't require a human to scribe the test result from a visual looking at a stick to a piece of paper to a computer system. Because every time a human involved, we err.
Yeah. So this is quite fascinating because you're reducing human error in this process. You're providing a responsive approach to the resident client or patient. You are ensuring they get the best care possible based on the results because it's timely. Staff are protected too in this process. Like, this just seems like a win-win.
Yep. And that kind of leads into one of the challenges being cost. When I mentioned the cost challenge, that's upfront spending. Mm-hmm. There's a bunch of studies to your point. There's a bunch of studies showing that in point of care environments, more generally, molecular testing for respiratory infection can end up being cost saving because the savings are realized somewhere else, right? In protective equipment or in isolation beds, et cetera. And if not cost savings, cost effective. So more money spent, but bringing value to society and life years gain, quality life years gain, things like that. So yes, I think there's a lot of advantages.
Mm-hmm. It seems very powerful to me. So Scott, anything further in terms of training for staff with molecular testing that you feel would be important for our audience to know?
So that goes to that second challenge of sort of quality management. A big part of quality management, or at least one of the, let's say, core pillars, is staff training. So staff have to be trained on the whole process, from the sample acquisition to the proper naming of the sample to the performing of the test, and then interpreting the data and storing that data. The device manufacturers and the federal government play a role in that the manufacturers should be designing tests that make all of this process as simple as possible for use in point of care environments. And they make that test and provide that information to Health Canada, and Health Canada reviews it and ultimately decides whether they feel that non-laboratory staff can run this test in a point of care environment. But ultimately, that responsibility for training will fall on the end users and the end environment. There are guidelines put out for point of care testing that speak to both the public and private long-term care sector that you can go look up. There's accreditation programs, Accreditation Canada. Obviously, there's the international ISOs that, as a part of their program requirements, can give a good idea of what a responsible training program looks like. And then another thing that can be done is go to a laboratory affiliated with a local hospital and learn from them what they're doing regarding training around their point of care program. So even a laboratory at a hospital will have oversight on point of care programs in and around their environment. And so they'll have a lot of experience with that as well.
So there's a lot of rigor here in terms of staff training and a lot of guidelines and standards to ensure molecular training occurs for staff in a really healthy, positive way.
Yes, I think on the one hand, as I was mentioning, there's responsibility on the manufacturer and the regulators' parts to ensure that these tests that are recommended for point of care environments are simple, are easy, are as much as humanly possible foolproof and fail-proof. Mm-hmm. But the training and the documentation of the training still has to be done. And there's a lot of sources of guidance and recommendations out there to be followed that can be followed. Yeah.
Great. Thank you for that. So Scott, how do you envision the role of molecular testing evolving over the next decade?
Yeah, good question. I think we're going to see continued development along the two branches that I had outlined earlier. I think we're going to see more and more complex tests that are able to provide more and more data from a single specimen, getting into hundreds, if not thousands of pieces of information. And for at least the next 10 years or the foreseeable future, in my mind, up to debate, of course, but in my mind, those technologies are going to largely stay within traditional laboratory environments. In the other branch, we're going to continue to see this development towards simpler and simpler, fail-proof, perhaps only looking at one target or two, assays that are really, really amenable to decentralized point-of-care systems. And we're going to see more and more testing moving out of traditional laboratories, out of traditional healthcare, and ultimately, to some degree, democratizing testing. And now, obviously, that has to be done responsibly. It has to come with this quality element and this data management element that we've discussed. But in terms of the test design themselves, I think we're going to see more and more innovation in that direction.
Fantastic. That's really good to hear. So, Scott, can you share any case studies or real-world examples where molecular testing, significantly impacted the patient care in a long-term care setting?
Yeah, so like I was mentioning earlier, similar to the cost studies I was mentioning earlier, there's a lot of studies, or a good amount, demonstrating that point-of-care testing for respiratory infections in general leads to better outcomes. Like we mentioned, earlier access to antivirals, meaning more therapeutic benefit from those antivirals. For influenza in particular, it allows you to start treating with some anti-influenza drugs prophylactically, so you can shut off an outbreak quicker. You're not wasting antibiotics by using them inappropriately when it's a viral infection. Stuff like this. I think what we're lacking is data in the long-term care, critical care, long-term care environment in particular, and perhaps region specific. So, Alberta data. Mm-hmm. There is one study that I know of where they evaluated point of care testing for respiratory infections versus sending the test samples away to a local laboratory. Obviously, when they use the point of care test, they get the results in a order of minutes. I think the average was somewhere around 35 minutes. Whereas if they send the samples away, the results come back in an order of 35 hours. And that difference translated into the homes with access to the point of care testing being able to declare an outbreak many, many hours sooner than the homes that needed to wait for the results to come back from another location. Now, presumably that means that once you've declared the outbreak, you can get the treatments quicker and it'll lead to better outcomes. But that data, I think that argument needs to be fleshed out in Canada and made more solid.
That's a really good point. That's a really good example. You know, the fact that you can deal with an outbreak quicker, right? Time hasn't gone by. You know, actually the responsiveness now becomes your friend in a long-term care facility, actually. Okay.
Absolutely. Yeah.
So, Scott, are there any ethical concerns related to the use of molecular testing in long-term care settings? And if there are concerns, how would they be addressed?
Yeah, I guess there's ethics in all things. You know, you want to be doing what's right. Two things come to mind. One, the question, going back to the discussion around data management, there's a question of data ownership. You know, when you're performing these tests, how are you ensuring that the patient or the patient's family has access to the results, has a degree of determination on how those results are used? You know, some of these results are going to be reportable and should go to the province. So how do you navigate that relationship of who owns the data? Second is, you know, when we think of any kind of healthcare, but we can speak of long-term care specifically, not all places in Canada, not all peoples in Canada will view healthcare in the same way as you and I. I'm thinking of, or healthcare and the way healthcare should be administered. I'm thinking of, you know, Indigenous populations, other populations in perhaps rural, remote, isolated areas. And so when offering this testing or providing testing, that has to be done in a way that makes cultural sense for the end patient. And so, you know, that has to be navigated as well.
So, and that requires a lot of education and training, but particular education, information sharing about molecular testing in our system, which can be done.
I think, you know, it's not these. It's a good point. I don't think these ethical concerns are specific to molecular testing per se. And I certainly don't have all the solutions, but I think, you know, conversation and dialogue is obviously the right place to start. And just open sharing and figuring out, you know, how these tests should be administered in a way that all parties involved are left to feel good. You know, that's what ethics is, you know.
Yeah. So that they feel informed, they understand the process, the timeliness, the responsiveness, the outcome.
Yep. Ownership when appropriate, involvement in decision making when appropriate. Absolutely.
Great. Okay, thank you for that one. So how important is collaboration between researchers, healthcare providers, policymakers, and other decision makers in advancing molecular testing for respiratory diseases?
So great question, and short answer, paramount.
Yep.
I think, you know, as I've mentioned a couple of times now, there is some great evidence out there to the benefits and the cost effectiveness of point of care testing in general. I think one potential limiter in adoption is the need for region specific data, you know, long-term care specific data. So I think really the test manufacturers, the healthcare providers, the researchers should be partnering to some degree to perform those studies and generate that information that they can provide to decision makers to support adoption. I think those studies have to be in a way that done in a way that maintains, you know, scientific and medical integrity. You know, so and avoids the perception of influence from the manufacturers, right? So, you know, the manufacturers have to be creating space where these studies can be done, but not in a way that can result in unintended influence. And ultimately, you know, these studies take money to conduct and take time. And so I think the provinces and other bodies that have funding and towards these interests should be freeing up funds to to allow those studies to occur in order for the decision makers to make their decisions in the most informed manner possible.
Well, ultimately improves patient care.
Right, in an evidence-based way.
Yeah. Which ultimately improves quality of care, whether you're in a facility or maybe you're in your home environment through this testing, because it's administered, with integrity and clinical effectiveness and all that. But it's the outcome for the individual and the outcome for the system that's really important too, right? It's cost effective. People can get ahead of an issue before it's sort of out the door, right? Like, I think it's got such great opportunity.
Yeah, and I've spent a little bit of time talking about cost and cost effectiveness, and that's a part of society and that's a part of decision making. But really, to your point, this can be a great benefit to individuals, to their families, to their peers by preventing, onward transmission. Mm-hmm. And I think also in terms with the ability to lead to someday more democratic testing systems, it has the opportunity of really hitting the Canadian ideal of, equal or at least equitable healthcare for everyone, whether they live hours and hours away from a hospital or not.
Mm-hmm. And it's got really positive potential impact for workplaces, right? In terms of the responsiveness of the testing at that point of care, right? Like,
Yep.
People aren't staying away from work, let's say, for 7-10 days, things like that, because it's sort of getting in front of a situation.
Yeah. And I mean, which could cut both ways. If because of the extra sensitivity of a molecular test, it's more likely to detect an infection in that first day where, you have a scratchy throat, mm-hmm. and the very first day of symptoms, and you might be lying to yourself that I feel sick. And so it can prevent healthcare workers becoming infected, but it could also, in theory, prevent healthcare workers from bringing in outbreak if they, get that result on day 2 of their symptoms and say, "Oh, I have influenza. I'm not going to work."
Yeah,
and if I don't, I am.
Yeah, but it's also maybe a tool because we have a shortage in the health workforce, right? We have a tool that people can take care of their health because it's a responsive tool. So you know what you're dealing with fairly quickly, 35 minutes, and you go from there and you manage around that, right? But then maybe it won't impact like other aspects of one's life, right? Such as your work life.
Yeah, absolutely. Absolutely. And I guess just to your point of sort of the resource constraints around healthcare providers, healthcare workers, these tests, although they can take 35 minutes to an hour, depending on the test, typically are fairly hands-off. Mm-hmm. So they only really take a minute or 2 of human time in that 35 minutes. So not a huge burden on the staff that already have other priorities and might not be too interested in having all these new priorities or like these new work aspects to their workday.
Great. So Scott, can you think of anything else that you feel at this point would be helpful for our audience to know? Did we miss anything?
No, I can't think of anything. It's been a real pleasure. I'm happy to address any questions, comments.
Okay. So Scott, thank you for joining us today. This was a really insightful and an important conversation. And I think what your system is doing is very helpful to continuing care, particularly in Alberta. I think this is an important step going forward in enhancing respiratory health for those in long-term care and what we'll call in Alberta continuing care. To our listeners, be sure to tune in next month when we switch the conversation to Navigating and Continuing Care, following insights from experts at the ACCA November member meet. Thanks for listening, and we'll see you next time on the Long-Term Forecast.